everybody. Good evening. So today we're going to discuss cancers in women, preventing and detecting gynecologic cancers. I have no disclosures. In terms of some learning objectives, I'd like us all to be able to identify signs and symptoms of gynecologic cancers that are worrisome and should prompt further evaluation. Identify modifiable risk factors for gynecologic cancers, and finally, identify interventions that can reduce our risk of gynecologic cancers. So I always like to start with an overview of what the gynecologic organs are. So this is a very basic schematic. So we have the uterus, and the cavity inside the uterus is called the endometrium. We have the cervix, the vagina, and then we have the fallopian tubes on both sides and ovaries on both sides. We're going to focus on three main cancers today, and they are uterine or endometrial cancer, ovarian cancer, and cervical cancer. In terms of uterine cancer, this is the first cancer that we're going to speak about. And if you look at cancers as a whole, cancer is the second leading cause of death in women in the US, and the first cause is heart disease. Uterine cancer originates here in the uterus in the endometrium. This is some little bit older data from 2019, but it's the fourth most common cancer in terms of new cases. And then it is also the sixth most common cancer in terms of death from cancer per year in the United States. The average woman in the US has a 2.8% lifetime risk of being diagnosed with uterine cancer. The average age at diagnosis is 62 years. 75% of women are postmenopausal, meaning they are done having a monthly period. 25% of women are diagnosed when they are premenopausal, meaning they're still menstruating, still having a monthly period. 5 to 10% of patients diagnosed with uterine cancer in the US are less than 40 years old. There's a few risk factors for uterine cancer. Genetic predisposition to uterine cancer is a big risk factor if that's something that affects a patient. The most common one that we think of is something called Lynch syndrome. This increases the risk of uterine cancer as well as colon, prostate, pancreatic, a host of other cancers as well in families that have Lynch syndrome. The main one I want us to focus on is obesity and being either obese or overweight. This significantly increases the risk of uterine cancer. If you look in the second row here, obesity greater than 50% over a person's ideal body weight increases the relative risk of uterine cancer by a factor of 10. Protective factors against uterine cancer: pregnancy, having age at first period being older than 15 years, which is definitely on the older end, and using oral contraceptive pills, birth control pills. All of these things are protective against uterine cancer development. The vast majority of patients that have uterine cancer present with abnormal uterine bleeding. In a woman who has undergone menopause and she has stopped bleeding, such a woman should never have vaginal bleeding again. The way that we are taught in medical school and medical training is that postmenopausal bleeding, meaning bleeding after the time of menopause, is endometrial cancer until proven otherwise. So I really want to focus on this point because this is something I have found many women don't know. Many women don't realize that bleeding after menopause is never normal. Even if you are stressed, even if it's just a little bit of bleeding, even if it's just brown or pink, if it's not bright red, it still counts. Sometimes patients will tell me, well, it's only bleeding after I wipe when I use the bathroom. That still counts, still abnormal, and you should still speak to your doctor about it. It still counts as postmenopausal bleeding. In terms of women who are still having periods, if you are experiencing bleeding between periods or getting 2 periods a month, or all of a sudden your periods are one way and then they become very different. For instance, if you usually have moderate bleeding with your period, but now all of a sudden you're having very heavy periods and that's not normal for you. Those are all abnormal signs that you should speak to your primary care physician or your gynecologist about. Other symptoms that are a bit more subtle for uterine cancer are pelvic or abdominal pain and abnormal vaginal discharge. In terms of signs, which are things that your physician would be able to pick up on if they detect a pelvic mass during your exam, or if you undergo imaging, such as an ultrasound, and you have what's called a thickened endometrial stripe. So the lining of the uterus appears thick. Those are also signs of endometrial cancer. In terms of being overweight or obese, I think this number has gone up since this statistic here. But at least 65% of the American population is overweight or obese. The reason why this matters for uterine cancer risk is because as women, we have 2 main sources of estrogen, our ovaries, but then after menopause, those ovaries stop making estrogen. The other main source of estrogen is actually in our fatty tissue, adipose tissue. Adipose tissue converts testosterone, which all people, men and women have. Women have a small amount of testosterone, but our fatty tissue converts that testosterone to estrogen. So if you have extra fatty tissue, your body is going to convert testosterone into extra estrogen. That estrogen stimulates the endometrium. It stimulates it to undergo many changes, many turnover cycles. And this increases your risk that one of those turnover cycles will have a mutation that causes endometrial cancer. So that's how obesity has a direct role in the development of endometrial cancer. Being overweight or obese accounts for at least 20% of cancer deaths, all cancers, in American women. So when, we talked about how estrogen, people have extra estrogen from their fatty tissue, and that increases your risk of endometrial cancer, but it doesn't stop there. The effect of obesity doesn't stop at that point. When people are obese, it makes the treatment for endometrial cancer a lot more risky. It makes surgery more risky. It makes, if you're going to get radiation, it is challenging to dose radiation when there is a significant amount of fatty tissue. Also, even in terms of dosing chemotherapy, we're not, at this point, we don't have a great understanding on if we should be dosing chemotherapy at the same rate in patients who are obese or significantly above their ideal body weight. Lynch syndrome that we discussed before, this is a specific genetic defect in genes that help to repair DNA. So in patients who have this genetic mutation, when their cells undergo changes, genetic changes that lead to cancer, their DNA cannot repair that. So they do have increased risk of colorectal and endometrial cancers, as well as ovarian, stomach cancer, small intestine, urinary tract, pancreatic, and certain types of skin cancers also. In terms of prevention of endometrial cancer, maintaining a healthy weight is paramount in this situation. Exercising, and that will improve your health in many, many ways, not just in terms of endometrial cancer prevention. The other thing is to know your family history. Know who in your family had cancer, what kind of cancer they had, how old were they when they were diagnosed with cancer. There's the alarm bells go off in my head differently when a patient tells me their mom had endometrial cancer diagnosed at age 90 versus a patient who tells me her mom had endometrial cancer diagnosed at age 45. From our standpoint, we offer genetic counseling for patients with significant family histories of colon, uterine, and ovarian cancer. So if these are cancers that are making a big appearance in your families, please talk to your doctor about genetic testing. Patients that have certain mutations called BRCA, specifically BRCA1 mutations, are at increased risk of endometrial cancer. When patients have these mutations and we know about them earlier on, then we actually recommend what we call a risk-reducing hysterectomy, removing their uterus entirely when they're done having children, or at the very most by the time they're in their mid-40s. The take-home message is here for uterine cancer. Having an increased BMI or body mass index leads to increased estrogen production. Bleeding after menopause always needs further evaluation, no matter the color, the quantity, the time it occurs, what you may think the reason is. Please speak to your gynecologist or your primary care doctor about this, as this always needs to be evaluated further. The way we diagnose endometrial cancer is with tissue sampling, either with a biopsy done in the office or in the operating room. Because this cancer has symptoms, most uterine cancers are diagnosed at stage 1. This means that most endometrial cancers can be surgically cured if you see your doctor in a prompt fashion. There's no effective screening test for uterine cancer. And finally, knowing your family history is paramount. The next cancers we're going to talk about are ovarian, fallopian tube, and primary peritoneal cancer. Ovarian and fallopian tube cancers are treated as the same entity as is primary peritoneal cancer. The peritoneum is the lining of the abdomen. Just like we have skin on the outside, inside the abdominal cavity, there is a lining that's called the peritoneum. This cancer also we treat in the same group as ovarian and fallopian tube cancers. Ovarian cancer, based on the statistics from 2019, is the 5th most common cancer in women to be diagnosed in the US. Ovarian cancer is a particularly deadly cancer. 75% of patients are diagnosed in advanced stage, meaning stage 3 or stage 4. This is a cancer that is difficult to treat because the cure rates are very discouraging. This is a cancer not only is diagnosed late, but the treatments we have also are not great for it. There's no effective screening test for this cancer, and 1 in 71 women will develop ovarian cancer in her lifetime. This comes out to about a risk of 1.4, 1.5% by age 80. We can talk about risks and protective factors for ovarian cancer. So having BRCA1 or BRCA2 mutation, or a female relative, particularly a first-degree relative, meaning a sister, a daughter, or a mother with ovarian cancer, increases your risk significantly. Older age, having issues with infertility, null gravidity, meaning not ever being pregnant, having a diagnosis of endometriosis, experiencing early menarche, so getting your very first period ever early on. Usually we say this is before age 11 or 12, so before that is considered early. Undergoing very late menopause. The average age of menopause is about 51 years in the US, so undergoing menopause after that is a risk factor. Protective factors are prior hysterectomy or tubal ligation, like having your tubes tied, and prior oral contraceptive use, prior use of the birth control pill, particularly when it's more than 5 years, is very protective against ovarian cancer. Ovarian cancer does unfortunately present late because it doesn't have symptoms that are easy to identify for most women. In the early stages, this disease does not have symptoms. It's what we call asymptomatic. In the advanced stages, the symptoms are still vague and nonspecific and don't really alarm most women until they're very bad. So these symptoms are pain, changes in urinary or bowel habits, seeing your abdomen get bigger, changes in appetite, such as getting full early or not having a normal appetite, and then having nausea, vomiting are also all signs. I have a lot of patients tell me, they come in with these significant sized ovarian cancers, and they'll say, you know what, I thought I was just gaining weight. I thought I was getting fat. Um, so I think if you're in a position where you start to experience that, I would have a very low threshold to see your doctor and talk about it, because it might actually be that there is, you have a mass in there, and that's what's actually causing you to gain weight and appear bigger when it doesn't make sense to you. Signs that your physician would find are pelvic mass, or what we call a fluid wave. These cancers make a lot of fluid. So on physical exam, you can tell that it's fluid inside the belly. This isn't so much of a problem here in the Northeast, but in other states where they might not have a gynecologic oncologist in the whole state, or in, the surrounding area, this is an issue. But we know from studies that getting treatments from a gynecologic oncologist for ovarian cancer is one of the best ways to reduce mortality or death from ovarian cancer. So there's various genes that cause susceptibility to ovarian cancer. The main ones are BRCA1 and BRCA2. These are this is the genetic mutation that Angelina Jolie has. And most people I find are familiar with that. BRCA mutations increase the risk of breast, ovarian, prostate, and pancreatic cancer. There is a significantly increased risk of ovarian cancer among patients with BRCA1 and 2 mutations, around the order of 40 to 50% increased risk on average, depending on the mutation that you have. The take-home messages for ovarian cancer are: these symptoms are often very vague, difficult to pin down. There's no effective way to screen for this cancer. These cancers are usually diagnosed at advanced stage. Again, it's very important to know your family history. If you're someone who can look at your family tree and say, well, this person had ovarian cancer, and this person had ovarian cancer, and this person had breast cancer, it should raise some red flags, and you should talk to your doctor about that history. And more than likely, they will recommend you undergo genetic testing. We have a saying here: ovarian cancer, it whispers, so we have to listen very carefully. Cervical cancer is not an inherited cancer, but it is a cancer that we can prevent. That's the main takeaway from cervical cancer, is that it is preventable. So there's an estimated 13,000 new cases and about 4,000 deaths to cervical cancer from 2019. From that same year, there was about 410 new cases diagnosed. This cancer affects women who are younger, so the average age at diagnosis here is 48 to 51 years old. The incidence, so how often cervical cancer occurs, and the death rate from cervical cancer is about 50% higher in women who are Black or African American. The main risk factor of cervical cancer is human papillomavirus. So cervical cancer, this is what I say is this is a sexually transmitted cancer, because human papillomavirus is a sexually transmitted virus. And the risk factors for that are having high-risk sexual partners, being immunosuppressed. So if you've had a transplant and you're taking immunosuppression, you're at higher risk of acquiring HPV and acquiring cervical cancer. And smoking cigarettes raises your risk of not being able to ward off HPV. A lot of these risk factors say having multiple sexual partners is a significant risk for cervical cancer and for HPV. But the reality is you can have had one sexual partner your entire life, and if they give you HPV, you are at risk. So I actually don't like to promote that line of thinking so much, but that really even just one sexual partner can lead to HPV, which can lead to cervical cancer. Symptoms after cervical cancer, a lot of times women will not have symptoms, but the big one that we see tends to be bleeding after sexual intercourse, which is often not heavy, can be subtle bleeding, can be just spotting, but this is not normal. And then also having excessive discharge and abnormal bleeding between periods. With cervical cancer, it's very important to pay attention to these symptoms because this is a disease that affects women who are still on, for the most part, still having monthly periods. So having vaginal bleeding might not raise any alarm bells. So we have to really pay attention to when this bleeding is occurring, if it's outside of the regular time of the menses. So the way that it works is that you start with normal cervical cancer cells, and then they undergo, when you're exposed to HPV, most patients clear the HPV spontaneously on their own. In other patients, that HPV persists and it causes a pathway of precancerous changes, or what we call dysplasia. And then finally, at the most severe level of precancerous changes, the cells become cancer. The average amount of time from infection with HPV to the development of cervical cancer is 15 years. The way that we screen for cervical cancer is through a pap smear. So when you go to your gynecologist and they insert the speculum and they use the little brush to collect cells, that is screening for cervical cancer. This is one of the most successful cancer screening campaigns globally in the history of humanity. And it's really a model for screening for all different types of cancers. So this is a preventable cancer. The way that we can prevent cervical cancer is through screening, correct? Because you can identify when the cells are undergoing those precancerous changes and you can intervene. But we can even prevent that from starting by vaccinating people with an HPV vaccine. This vaccine has been around since the early 2000s. Currently, the HPV vaccine is approved for females and males up to age 45 years old. So this is a vaccine that's recommended to be given actually in the pediatric population between ages 9 to 11 to boys and girls. The key to giving it so young is twofold. The first one is you want to be sure that you're administering the vaccine before any possibility of sexual activity. The second is children are able to have a more robust immune response. So they're able to respond to the vaccine more robustly and make antibodies more robustly compared to an adult. This vaccine is a dead vaccine. It cannot cause HPV infection and it cannot cause cancer. And it produces higher level of antibodies than if someone were naturally infected with HPV. Currently, there's actually only one form of HPV vaccine available in the US. This is called Gardasil. It protects against 9 strains of HPV, 4 of which are the highest risk strains of HPV. Typically, this is a 3-dose vaccine, and again, is approved currently until age 45. This is something that you can obtain at your primary care doctor's office, your gynecologist's office, or even at your pharmacy. People who should not receive HPV vaccination are those who have an allergy to Gardasil. So let's say they were vaccinated with the first dose and they developed a severe allergic reaction, they should not continue. Patients with an allergy to yeast or these other compounds listed here. Patients that are very sick right now, like patients who have the flu or a very bad cold, should wait until that resolves before getting the vaccine. Pregnant women should not be vaccinated. Mainly this is because we don't have data in this population. If someone is vaccinated with HPV vaccine and they did not realize they were pregnant, it's okay. It's not a cause for alarm, but this is just not recommended. We do have proof that this vaccine works very well. And actually in countries that have very robust HPV vaccination protocols, such as New Zealand, they have nearly eliminated cervical cancer. So in 2003 to 2006, about 12% of people ages 14 to 19 were infected with HPV strains shown here. But then in 2009 to 2012, that number had dropped to 4.3%. Within 6 years of the vaccine's use, there was a significant decrease in the prevalence of the most dangerous strains of HPV. That was a 64% decrease in girls 14 to 19 and a 34% decrease in women 20 to 24 years old. Our vaccination rates against HPV in the US are not great. Nationwide, only half of boys are vaccinated against HPV, and 40% of girls are not vaccinated against HPV, even though this is standard recommended vaccination. The take home for cervical cancer is ideally everybody should be vaccinated against HPV before onset of sexual activity. We have age appropriate cervical cancer screening in the way of pap smears that we should all continue at the advice of our doctors. And then quitting smoking not only will decrease your risk of cervical cancer, but will help you live a healthier lifestyle in all aspects. So we can summarize the presentation here. 40% of endometrial cancers are potentially preventable through maintaining a healthy weight and healthy lifestyle. Bleeding after menopause always requires further evaluation. And talk to your doctor about genetic counseling if you have a family history suggestive of familial cancer syndromes. In terms of ovarian and fallopian tube cancers, 5 to 10% of these are potentially preventable by knowing your family history and undergoing genetic testing. Keep in mind that ovarian cancer is a risk if you've been experiencing unusual abdominal, pelvic, or bowel symptoms that persist for more than 2 weeks. For cervical cancer, our takeaways are that HPV vaccination is ideal if age appropriate. Again, that's up to age 45. Ensure that you're undergoing your pap smears and quit smoking. These are all our ribbons for our various gynecologic cancers. And this is my information here. Thank you.
Thank you very much, Dr. Saleh. Really great presentation. And Maureen, if you'd like to unmute, you could get started with the yoga portion, and then we will answer questions at the end for anyone who has questions. Thank you.
All righty. So you can do these stretches in a chair. You can sit down like I am, whatever you're most comfortable with. We're going to start out with just a little bit of breath work and then a small meditation, and then we'll get into some gentle movement. So gently close your eyes, just noticing your breath. We'll breathe in for 4, hold for 4, exhale for 4, and hold for 4. We'll repeat that, breathing in for 4, hold for 4, exhale for 4, and hold for 4. One more time, breathing in for 4, hold for 4, exhale for 4, and hold for 4. Keeping your eyes closed, we're just going to gently walk ourselves through each part of the body and relax that part of the body as I mention it, keeping your eyes closed, beginning with your toes, the soles of your feet, your ankles, your calves, your shins, relaxing the knees, relaxing the hamstrings, relaxing the thighs, relaxing the hips, relaxing the sits bones, relaxing the belly, relaxing the lower back, relaxing the chest, relaxing the upper back, relaxing the shoulders, relaxing your fingers in your lap, relaxing your hands and your wrists, your forearms, your elbows, your upper arms, Relaxing the neck. Relaxing each of the muscles in your face. Relaxing the back of the head. And relaxing the crown of the head. And keeping your eyes, we can bring our eyes open. We're going to begin some gentle movement. We're going to start with just lifting our arms up over our head. And then bringing them straight down into the heart center, right? So your hands are right at your chest. And we're going to reach up a second time, bringing our palms together and then bringing them right back down. And the third time, we're just reaching up, palms together and bringing our arms down. We're going to take our right arm across our body, bringing our left hand just behind the elbow, and gently pressing in so you could feel a nice stretch through your shoulder. And then we'll switch arms, bringing the hand behind the left elbow and pressing in just a little bit to stretch the arms. We'll bring our hands behind us, bringing our hands together, and then gently leaning forward, gently lifting our hands up off our back to feel a nice stretch through the arms. We'll slowly come back up, bringing our hands onto our laps. We're going to take our right hand over to our left knee, bring our left hand behind us, and inhaling and pulling the belly in and gently twisting over towards that left shoulder, feeling a nice stretch through the back. Come back to center, bringing our left hand onto our right knee, our right hand behind us. Taking a nice deep breath, twisting over towards the right shoulder, feeling a stretch through the left side of the back. And make sure you're breathing as we go through these exercises. It helps to increase your movement. We'll come back to center. And we'll gently walk our hands out towards the center. Gently leaning our hips forward, feeling a nice stretch through those hips. Gently come back up. We're going to come up onto our hands and knees. You can. So we're going to place our palms just underneath our shoulders. Our knees are just underneath our hips. And from here, we're going to take a nice big breath in, pulling back up the spine up towards the ceiling. And then gently exhale, flattening the back, opening up through the chest and bringing the chin forward. So repeat that. Inhale, spine up towards the ceiling. Exhale, flattening the back, opening up through the chest and bringing the chin forward. One more time. Inhale, spine to the ceiling. And exhale, flattening the back, opening up through the chest and bringing the chin forward. Good. From here, we're just going to sit back onto our hips. You can bring your knees a little bit wider apart, gently bringing our chest down towards the mat and our palms out towards the center of the room. This child's pose. Still breathing. And we'll take our left hand off to the side of the mat, bringing our right hand on top. Again, gently sitting down towards our butt, down towards the hips. And we're going to gently lean, feeling a nice stretch through the right side of the body. We'll come back through center. Right hand off the mat, left hand on top, and gently sitting down, feeling that nice stretch through the left side of the body. And we'll come back into a table. Gently reaching our right arm out in front and gently stretching the left leg back. engaging our core, keeping a nice flat back here. We'll come back into a table, reaching our left arm out in front, right toes back. And coming back into a table. Come back down into a sitting position. Reaching our legs open just a little bit, gently walking our hands towards the center. Feeling a nice stretch in the inner thigh. And we'll slowly come up, bringing our feet together, pressing our elbows into the inside of our knees, and gently pressing down, leaning forward if you can. Again, feeling a nice stretch through the inner thigh. And then we'll straighten both legs. Going to take our right foot to the outside of our left knee, taking our left hand onto our right knee and twisting over towards the right shoulder. Another stretch for the back. And come back to center, bringing the left knee over to the right side, right hand on left knee, twisting over towards the left shoulder. And we'll come back to center. Just going to stand up a little bit, so I'm going to have to move my camera back. Alrighty. So we're just going to inhale our arms up, bringing them down through heart center, gently bringing our hands down towards the mat. Take a nice inhale, bringing our hands to our shins. Slowly exhaling, bringing our hands back down towards the mat. And then we'll just inhale our arms wide, reaching them up towards the ceiling. Hands through heart center and back down. We'll do that 2 more times. So gently inhale, reaching our arms up towards the ceiling. Exhale, hands through heart center, bringing our hands down towards the mat. Inhale, half lift. Exhaling our hands back down to the mat. And we'll inhale, arms wide, reaching them up towards the ceiling. Bringing our hands through heart center and bringing them back down. And we'll do it 1 more time. Inhale, arms up. Exhale, forward fold. Inhale, half lift. Exhaling our hands back down towards the mat. And we'll inhale our arms up towards the ceiling and bring our hands back to heart center. Stepping our feet just a little bit wider. Going to take a gentle twist towards the left. Bring the left hand behind us and the right hand out in front. And we'll come back to center. Bringing the left hand out in front, right hand behind. And we'll come back to heart center. Reaching our arms up towards the ceiling. Then bringing our right hand down, grabbing onto our right elbow, and bringing it up towards the center of our head. And we'll reach up, bringing our left hand down, bringing our left elbow towards the center of our head. Bring it out to the side and gently just pressing the chest open, reaching the chin up towards the ceiling, feeling a nice stretch through the chest. And you can give yourself a nice big hug. We'll stretch our arms open again, really stretching the chest, bringing the chin up towards the ceiling. And we'll come back down, reaching the right arm over towards the left side, keeping that right foot solidly pressed into the mat. Feeling a nice stretch through the right side of the body. And we'll come back to center, reaching the left arm up over towards the right side. Feeling that nice stretch through the left. We'll come back to center. Bring back down onto the mat. Bring our left leg back, right leg out, and gently lean down towards the right knee, feeling a nice stretch through the back of the right leg. And we'll slowly come up, bringing the left leg out in front and the right leg back, gently leaning towards that left knee. Feeling a nice stretch in the back of the left leg. And then we'll bring both feet together, gently leaning our chest down towards the knees. Come back to a sitting position. Again, gently closing our eyes, letting our hands rest on our knees. And taking a nice deep breath in through the nose and out through the mouth. Just imagine a beautiful red ball of light sitting at the base of your spine. And as it ignites and it becomes more red and more open, it moves up just to the base, a little further up the base of the spine to the sacral, which is an orange wheel spinning in a clockwise motion, gently moving up towards the solar plexus, which is an orange wheel spinning and glowing brighter. Coming up to the heart chakra, which is a blue wheel, spinning in a clockwise motion. And coming up to the throat chakra, which is a light blue wheel, spinning and glowing and relaxing. And coming up to the forehead, which is a purple light, another wheel spinning and glowing. And then coming up to the top of the head, or the crown, which is a beautiful white light as it showers down over us. Taking a nice deep breath in through the nose and exhale through the mouth. And bringing our hands together and just gently leaning their head forward. Namaste.
Namaste. Thank you very
Yes.
much, Maureen. And we can take questions now for anybody who has questions. And also, I put the survey. If you could kindly complete the survey, I will be staying around too, so you'll have some time to complete that even after we're done. And also, I have the recording link if you're interested in the recording. They're both in the chat box. Thank you. So, any questions?
I would just like to ask a question actually. With the BRCA gene, why is it so difficult for insurance to cover the testing of that?
It's really not, in my experience, it's not difficult. If you have, ideally, it's the person in the family with the cancer that gets tested. So if, it's your cousin or your grandmother, or whoever has breast or ovarian cancer, if they get tested, that's the most likely situation where it'll be covered. And then if they are positive, insurance really should cover you getting tested for it.
Okay. Thank you.
So I think that is it. I want to thank both Dr. Saleh and Maureen for speaking tonight. And again, I will stay if you'd like to answer the survey. If one of the speakers would like to comment on the other, you're welcome to do that, or any additional comments. The survey link is in the chat box, and also, like I said, the recording link, and it will take about a week or two to get that recording posted. And thank you to those who attended tonight. And as I said, I will remain here a few minutes to give you time to complete the survey. Thank you.
Thank you.